Well, good evening, everyone. My name is Jay Mead. I'm a pathologist by training, and by way of introduction, my claim to fame is that I'm a pathologist who sees warm patients. And I've been doing that now for 20 years, and it's been an exciting practice for me. And the focus of my practice since I've started in clinical medicine has been in complementary alternative medicine. And that's how I met John Brimhall 10 years ago. I went to one of his homecomings and met holistic chiropractors and got excited about what they're doing, and we ended up sharing some clinical information. And what I'm going to do for you today is to introduce you to saliva testing and show you how all of that's evolved. So I'll get started on that. And I also want to mention, toward the end of this presentation, I will leave time for questions and answers. And so be thinking about what you might want to ask me, as we go along. So I'll get us started here. One of the first things I want to remind us of is the Women's Health Initiative study that came out in 2002, and the public became aware for the first time that the pharmaceuticals that the allopathic community had been prescribing were actually harmful. And that's the Health Initiative study, and it showed an increase in breast cancer in the study arm, also heart disease and stroke. So the public became very interested in that time about bioidentical hormones, and that will be our focus. Toward the end of this, we'll go through a case, and I'll show you how to manage these cases, or at least give you a whet your appetite. The understanding of how to treat, etc., does take a little more time than an hour, but right now we're going to focus on testing. So hormone testing has evolved. Serum testing was introduced into the medical community in the 1930s. Urine testing came along about 1970, and salivary testing has been around a lot longer than most of us. And certainly, speaking for myself, I wasn't aware of saliva testing until about 1998. But it's been around since 1983. And then here's the scoop. Looking at saliva versus serum versus urine, and what I want to emphasize is that first column under saliva, all the answers are yes. So it, number one, measures unbound active hormone. It measures the daily production from organs. You can use it to monitor your topical hormones. You can use it to monitor your injectables, and you can use it to monitor your oral hormones. Serum, on the other hand, does not routinely measure the free or unbound active form, can measure daily production of organs, cannot be used to monitor topical hormones, can be used to monitor injectables and oral hormones. Urine, on the other hand, does measure the unbound hormone fraction, but mainly the metabolites of these hormones. Can measure daily production, cannot be used to monitor topical hormones. You can monitor injectables and oral hormone administration with urine. Now, the other point to make as we're looking at this slide is that bioidentical hormones are best delivered topically. We know, for example, Estradiol, or E2, if it's swallowed, it lowers IGF-1 levels, which essentially is lowering your growth hormone function. And so we want to use that topically. Progesterone can be swallowed, but it's metabolized very quickly. It can be injected, however, it's very painful. So that should be administered topically. Testosterone, if you swallow it, gets metabolized very quickly unless it's in the methylated form, which is toxic to the liver. So that should be delivered topically or intramuscularly for males. Women, topically is the usual mode of application for testosterone. DHEA can be actually is the one hormone that can be swallowed and is effective that way. All right, let's break these down. Serum has been around for a long time, and it's been considered the gold standard. It's convenient in that as long as you have a needle in somebody's arm, you can order other tests, so you can get a battery of tests with one sample. It can be used for monitoring those injectables and oral hormone supplementation. The obstacles with serum are quite a few, starting with, again, you're not measuring free levels, and I'll address the free testosterone question in just a moment. It's very stressful to the patient, requires needles, and I'll show you a study that validates that. Of course, it's only limited to putting a needle in a vein, which is often inconvenient to the patient. The samples are unstable, require refrigeration and freezing if you're going to be shipping them around. Will not be sensitive enough to detect functional distress and conditions. It's ineffective when used to monitor topical hormones, and I'm going to go into that and the reason for that in greater detail. The free testosterone level that you get if you can order blood is basically a calculation. And it's a calculation using the total testosterone level, sex hormone binding globulin, and albumin. Now, this isn't the exact formula for that. This is a formula for the free androgen index, which you can use as a practitioner if you get a total testosterone level. You just simply divide it by the SHBG, or sex hormone binding globulin level, multiply by a factor to convert the nanomoles of SHBG to nanograms, and the result of that equation should be between 0.7 to 1. If it is not, there's a problem. A low index indicates insulin resistance and or diabetes. Here's a study that shows that when you point a needle at somebody, their ACTH level goes up. So even if the laboratory were open at the time in the morning when you'd want that cortisol awakening response, which is 30 minutes after you awaken, that's the peak of it, you likely wouldn't get an accurate result because of the stress of the venipuncture. And we'll have some more studies to show you as we go along. Urine, on the other hand, doesn't require needles. It is fairly stable in terms of its shipping. You can measure the metabolites. In fact, that's all you can measure. There is interest in the 2,4,16 hydroxyestrone ratios, and urine is very functional for that. And you can monitor injectables and oral hormone replacement. Disadvantages, spot urines are subject to peaks and troughs. It does not measure actual progesterone levels. You're only measuring metabolites. 24-hour collections have a very poor compliance, up to 40%. Therefore, it's inconvenient to the patient and the office staff, and it's ineffective, again, just to reiterate, for monitoring topical hormone replacement. Saliva, on the other hand, as we move along, is very functional for looking at the free or unbound portion of the hormone. So you're actually looking at the bioavailable level. Advantages, you can diagnose any condition related to hormone excess or deficiency using saliva. You can use it to monitor your treatment. It's simple and convenient. And the woman in this photo is actually using one of our collection kits, collection tubes from Labrix Clinical Services, which only requires 2 to 3 minutes of time and is very convenient. Of course, it's stress-free and it's actually very reasonably priced compared to other lab tests. Other advantages, you can send a collection kit home with your patient and request that they provide a sample during the appropriate time of the month with women, and often women are using these kits. So you can determine what part of the menstrual cycle you want to check, and that's usually day 19 to 21. No special processing is required. The hormones are stable for prolonged periods of time. These kits can be shipped by Postal Service, UPS, or FedEx. And they are representative, again, of the bioavailable level of the hormones. And the only effective method to accurately measure topical, transvaginal, rectal suppositories, or sublingual hormone supplementation. And, of course, you can monitor your oral, subcutaneous, and IM injection as well. Limitations. Saliva is generally restricted to the steroid hormones, although we're starting to see some other analytes in saliva. Some of the inflammatory markers are being looked at now. But thyroid hormones and insulin are just not present in saliva in significant levels to be useful clinically. It is technically more challenging because you are measuring smaller levels than you would if you were measuring serum, so your laboratory has to be on their toes. The salivary specimen may come in contact with some of the topical or sublingual hormones on the hands and lips, or in the case of a sublingual, in the saliva, inappropriately in the saliva, so that contamination of the sample can occur. But we have methods and suggestions that help prevent that in our instructions to the patient. Spurious results can occur with periodontal disease. So bleeding can be a problem. However, that's very unusual in our experience, and we look at the sample very closely, and if it's blood tinged, we reject the sample. Now, this is one of the very first studies on salivary cortisol, and I'll just say right now, uncategorically, that cortisol should only be measured in saliva, and that's now becoming the standard, certainly in the complementary alternative field. In this study from 1983, they looked at healthy men and women and some that were pregnant. And they looked at the salivary levels of cortisol, and they compared it to serum, and they basically concluded that the saliva reflect the bioavailable cortisol level was unaffected by the binding protein, cortisol binding globulin. Stress-free, easy to collect. You can collect multiple samples, and multiple samples are key if you're looking at adrenal function. You need at least 4 samples throughout the day. And the laboratory is certainly not open during most of those times. And again, they're going to point a needle at the patient and skew the results. All right, we'll move along. And again, to reinforce the idea that saliva testing it's the only medium that will look at the bioavailable level, which is just a small fraction of the total hormones in circulation. Now here's a schematic diagram of the salivary gland. We have the capillary bed coursing along next to the gland, and within the capillary There's whole blood, and whole blood, as you know, consists of serum, which is water, and these hormones don't like water. They're lipophilic and hydrophobic, so they're going to want to ride and have to be moved around through the water by either attached to a protein, a carrier protein, or to a red blood cell. Now, once they're in the system and they're protected from the water, once the hormone passes an organ that has the appropriate receptor mechanism to pick that hormone up, the hormone will enter the cell, and in the case of the salivary gland, it enters the cell, passes through into the matrix, the salivary matrix. So that's a schematic of the salivary gland and the mechanisms by which the hormones are carried around. Now I want to show you some studies, and we'll get into why the topical hormones are not seen in the serum and urine in significant amounts. This study from 2000 was a study of 6 pre- and 6 postmenopausal women, and they were given 64 milligrams in a single dose of progesterone. Now that's a relatively large dose. Our standard dosing now is between 20 and 30 milligrams. And what they did was they monitored the serum progesterone levels, and they also looked at the urine metabolite of progesterone. And they noted that the salivary level was remarkable, showing appreciable levels within 30 minutes. And they concluded, if you look at the last sentence, no statistically significant change in the serum or urine levels. So that's one of the first studies that actually documented this problem. Now this is a study from Dr. John Lee's library, and what this shows is that within minutes, if you put a topical hormone on, and in this case it was 20 milligrams of progesterone, the salivary level goes up, peaks at about 2 hours, and drops back to baseline in about 2 hours. Whereas the serum level shows a very little change. And so we want to explain how that happens. Before we do that, I want to mention that if you apply a topical hormone to your patient or yourself, in approximately 21 to 22 days, the baseline, and I'll back up the slide, the baseline level will come up. So it won't drop back to a baseline. The baseline will raise, and you'll actually get a therapeutic level of the hormone. Now, how might this occur? Well, here's a schematic of the skin showing that right below the epidermis, or within the epidermis, we have capillary blood vessels in high numbers. Here's a histologic section showing the capillary bed within a few millimeters of the skin surface. And your compounding pharmacist, or compounds that Dr. Lohman and I have created, are readily penetrable to the skin because of the bases that are used for these hormones. And again, they're lipid soluble, and so they move through the skin layer rather efficiently. So the pat answer to how these hormones are carried around and elude the serum phase is that they must ride on a lipid-containing vehicle. And the only conclusion I can draw, and others as well, is that the main carrier are the red blood cells. They're the Uber hormone taxi service, so to speak. And there are papers in the literature that validate this. Here's one that was used by the blood industry where they looked at the amount of progesterone on the red cell surface, and because women make more progesterone, it turns out that progesterone actually is protective to storage progesterone increases the shelf life of blood. Another study that shows that 15 to 35% of all hormones are actually found on the red cells. So what happens when you put the topical hormone on the skin and right into those capillary beds? If you recall, the capillary diameter is 7 microns, and the red cell diameter is 7 microns. So those red cells are packed tightly in there, squeezing out a lot of the serum, and they're just readily available for the hormone to attach to. And here's a schematic showing what happens when you spin a tube of blood. The red cell area, the erythrocytes, go to the bottom. There's a little buffy coat layer, which includes the white cells and platelets, and then the plasma or serum. And of course, in the laboratory, the serum is decanted off, and the red cells are thrown in the rubbish. And in the case of a topical hormone application, you've just thrown away your hormone carrier. Now here's another function that's very important, and one of the reasons Dr. Lohman and I started Labrix was because we wanted to address this issue. And we did it through the way we collect the samples and process them. But here's an example of two women in luteal phase, and you'll note that their estradiol level here fluctuates radically based on a single sample. So this we understood based on our clinical experience and validated when we saw studies like this. So we decided to do when we started Labrix was to create a system where we would average the 4 samples that we collect throughout the day. And so basically what we do is we pool the 4 samples that are used for the cortisols, and we make a pooled tube, and from that pooled tube we measure the sex hormones, the estrogen, progesterone, testosterone, and DHEA. And that has been very effective. By the way, Labrix has been doing this for 10 years now. Now, just a reminder about the menstrual cycle. Over on the left, if you look at the bottom, we're looking at the endometrium, and on the left side, there's sloughing and bleeding, and that's menstruation. And that's day 1 is when the menstruation starts, or blood is noted. And as soon as the endometrium is sloughed, the next cycle begins, and that begins with the follicle in the middle schematic. And that follicle, which is eventually going to be the egg, starts to develop. And the lining around that follicle produces the hormone. And that during that first part of the cycle, the follicular part of the cycle, estradiol is the primary hormone. And that at the time of ovulation, when the follicle ruptures, there's a switchover and progesterone is developed. And the progesterone level then peaks. And when they both drop, the progesterone level drops and the estradiol level drops, then you have the sloughing and the cycle starts over again. And what we're interested in is that mid part of the luteal phase, or the second part of this cycle. I want to introduce Dr. John Lee, for those of you who may not know him. He was a pioneer in this field and coined the term estrogen dominance. He was a mentor of mine, and unfortunately he's been gone now about 12 years, but did amazing work, and mainly with progesterone and this concept of estrogen dominance, which we're going to get into in great detail. In summary, estrogen dominance is insufficient progesterone to balance against estradiol and what other estrogens there might be in our bodies, such as pesticides and herbicides. In addition to the progesterone issue from aging women and the drop in production of progesterone, particularly at the time of menopause, there are other factors that can exacerbate estrogen dominance, and they mainly include factors that increase the estradiol level or suppress progesterone production. And diet is an issue, excessive calories, impaired liver function. Environment, of course, we mentioned xenoestrogens. Stress, cortisol production, and of course, iatrogenic. And that takes us back to the Women's Health Initiative study that I showed you at the beginning of the presentation, birth control pills and conventional HRT. Briefly, this is John Lee's study he published in 1990, in which he showed that 30 milligrams of progesterone topically twice a day showed an increase in bone density in 100% of the patients, and routinely he saw a 10% increase in the first 6 to 12 months and 3 to 5% thereafter until they stabilized. Now, his study was not recognized as relevant. Of course, he was a kind of a maverick in the field, and conventional doctors didn't want to hear about this progesterone because they had the pharmaceuticals that they were using and the reps who were selling the pharmaceuticals to them. But I wanted to show you this study just to validate what he observed, this one and one other coming up. Here's a study that published in 2010 that shows that the periodontal ligaments in our oral cavities are actually a function of, their health is a function of progesterone. And so the conclusion from this study is that progesterone may play a significant role in osteoblastic function. Now, those of us in the field know that the conclusion should read, these findings show that progesterone plays a role in osteoblastic function. And then here's one. Here's another study. This is a review article from 2010 that shows that estrogen and progesterone collaborate in bone remodeling, and that progesterone actually stimulates the osteoblastic activity. And then if you look at the bottom line here, they looked at medroxyprogesterone, or Primpro, Provera, excuse me. MPA is Provera, medroxyprogesterone acetate, which again was part of that Women's Health Initiative study. And this effect was not observed with that synthetic hormone. So Dr. Lee's work with osteoporosis has been validated as correct. And furthermore, progesterone is extremely important for breast health. And here's a study that validates that. And it's a very interesting study, and I'm showing you more current studies. There are a number of studies. In fact, we have a bibliography if you ever want to contact us. We'll be glad to send you bibliographies on all of this. But here's a study that shows that the progesterone receptor, and hopefully if a breast cancer patient shows, hopefully she does show progesterone receptor activity, because that's going to be in her advantage. So you will give her progesterone, and what progesterone will do is upregulate factors from the nucleus, which have an anti-proliferative effect, and actually reduce the risk of recurrence of cancer and improve the prognosis. There are other studies that show that progesterone upregulates the p53 gene, which is an apoptotic gene. So back to this estrogen dominant concept, and this is Dr. Lee's work again. With what he observed in his patients that he was treating with osteoporosis is that he looked at their PGE2 ratio, which is progesterone divided by estradiol, And he discovered in those patients who received the topical progesterone, and who, by the way, I experienced not only increased bone density, healthy bone density, but also many of them reported that their PMS symptoms, their foggy thinking, their low libido, their anxiety and depression improved on the topical progesterone. But when he broke the code and started doing saliva testing on those women, he discovered that their PG2 ratios were somewhere between 200 and 400. And I'll show you a report from Labrix and give you some ideas of how you can correct that and where you would want to be on that. And by the way, the males also have a reference range, and that has to do with our prostates. That's in our brains and hearts, and that's a topic for another time. Now this slide is a schematic that shows you the precipitous drop in progesterone as a woman hits menopause. So if you think about the ovaries as the main factory, if you will, for estradiol and progesterone, as a woman ages, her estrogen level drops, but not at the same rate as the progesterone. And again, recall that it's the ovulation that produces the progesterone, and these women do not ovulate. Then you might ask, well, where then does the estradiol come from if the follicles aren't functioning? And the answer to that is that most women have excess adipose tissue, and in that adipose tissue there's an enzyme called aromatase, and that aromatase enzyme converts testosterone to estradiol, so that the majority of women do not need estradiol, but virtually 100% of them would benefit from progesterone. Now moving on to the CHANG study. This is the Sentinel study, and this was done in 1995, and I just want to go over it briefly with you so you see how potent progesterone can be relative to the estradiol effect. So in this study, there were 40 women. They were randomized into 4 groups. These women were going to surgery for excision of a benign lesion in their breast. One group was given only progesterone, another group was giving only estradiol at 1.5 milligrams, a huge estradiol dose, by the way, or both. That was the third group. And then, of course, there was the placebo group. The topical hormones and placebo were applied for 13 to 10 days only, I'll emphasize, 10 to 13 days before surgery. And when they looked at the normal breast tissue adjacent to the benign lesion, the control group on the very left showed essentially no hormone. Progesterone group found significant amounts of progesterone from, again, the topical application, and estradiol, very high level. And I emphasize that the 1.5 milligrams was a lot of estradiol. I mean, that's most of us, if we were going to give a woman estradiol, might start at a half a milligram a day. Now, the progesterone dose was 25 milligrams a day, which is the standard usual dose. And that's important to factor in as you look at this. And then in the combination group, both estradiol and progesterone were found in the tissue. But here's the crux of the study. They looked at the mitotic index, which they call the proliferating cell nuclear antigen, or pCNA. And that's just think of it as a factor, a mitotic factor. So the mitotic activity in the placebo group was 8. In the estradiol group, it doubled, and we would expect that since estradiol is a proliferative hormone. In the combination group, the mitotic activity dropped to below baseline. And in the progesterone-only group, it dropped to about 25% of the baseline activity. So progesterone is a very strong anti-proliferative hormone, and therein lies its benefits, particularly with breast cancer. So here's the conclusion of the CHANG study. Progesterone readily penetrates the skin. It induced a biological response, and they also noted, as we've emphasized before, there was not an increase in the serum progesterone level. And that goes back to the skin and that whole story that I told you before. Now here's something fascinating, and I know that many of you may be athletes or been in athletics. And did you ever wonder how an athlete like Barry Bond, for example, managed to avoid being discovered until very, very late in his career after he'd already broken Babe Ruth's record? Well, it has to do with the topical hormones not being detected in the urine. And here's an article from the doping literature, drug test analysis literature. And they show that the transdermal administration of testosterone showed a very high level in the saliva, but was not detected in the urine. So their bottom line is, it is likely that the significant increase in oral fluid is due to a pulsatile elevation of the free protein unbound circulating testosterone after the transdermal administration, and may be assumed to represent a more diagnostic marker of transdermal testosterone. Bam, I just heard the last nail go into the coffin of monitoring topical hormones in urine. All right, moving on. There's another ratio that's very important, and this goes back to Dr. Lemon's work on estradiol, or E3. And he showed estradiol to be protective. And for those of you who may not recall, there are actually three estrogens. There's estradiol, which we most commonly administer when it's needed. There's estrone, which we never administer. And there's estradiol. And Dr. Lemon discovered that estradiol was actually breast protectant. That is the good estrogen, if you will. And here's the ratio that Dr. Lemon suggested. That is that we look at E3, estradiol, divided by the sum of estrone and estradiol. And that ratio should be optimized at about 1.5. At 1.5, that's the lowest risk for breast cancer. And I will show you how to do that with supplements that you can use in your office. So here's the bottom line. Topically applied hormones are not detected proportionally in the serum and urine. I think we've got that pretty solid. The required topical dose needed to show a therapeutic response in serum or urine is 10 times or hypophysiologic overdosing. And this we know happens with Androgel and the pharmaceutical topical hormones. And what's important to know about that hyperphysiologic dosing is that excess hormone down-regulates receptors, and deficiency symptoms will recur, even though initially there'll be an amazing response. Of course, if you give someone 10 times the testosterone that they would have produced on their own, they can lift their car. However, 6 to 12 months later, they start to wonder why their erectile dysfunction has come back, and now their testicles are the size of raisins. So there are consequences to overdosing with hormones. And last but not least is the household contamination, which can occur. And there are studies that show, sadly, very significant household contamination and alteration in the children's physiology and gender issues. So if you are interested in saliva testing, contact Tom Lasota. He's our marketing manager, and he will be able to get you the information you need to get yourself going on Labrix Clinical Services. We would be delighted to serve you. Now, I also want to mention that our turnaround time is 2 days on average from the time we receive the sample. The report will go into your queue on our website, and it's secure. You have a password, login and password that only you can access. And all of your results are accessible, either those that you've done in the past or those that are current, will be readily available for you. Also, we have physicians who review and interpret every result, and they're available for phone consultations. And they're very good at what they do, and they'll direct you if you're not comfortable yet. I also want to introduce you to products made by Kajaran Inc. Kajaran is a company that my wife and I set up about 5 years ago, and we decided to make product that is clean. And these are all topical hormones. These are hormones that you can sell over the counter. They are, from a FDA perspective, considered cosmetics. We make no claims about their clinical benefit, at least in our advertisements and in the development of these products, and neither should you, by the way, if you choose to use these. However, I can tell you that the ones I'm going to describe for you here have USP grade hormone in them. First one is for balance, and this is the one that if you had this in your medicinary would be very popular, because virtually all the women you test are going to have a low PGE2 ratio, and they are going to want to correct that, and you can do that with this product. This is very cost effective. The wholesale price for you on this is $16.50. It's basically a 2-month supply because you get a 60 to 70 single pumps. And what you want to do is, that's 30 milligrams per pump, or 29.8 milligrams per pump, rounded up to 30. And that is generally enough for most women. And then you resell that for whatever you are comfortable with. If we sell it, if we retail it in our clinic, Aaron and I, Dr. Lohman and I, if we retail it, we sell it for $33, which is still very cost effective for the patient. Now, all these topical hormones should be applied to the thin parts of the body, inner wrist and behind the knees. And oftentimes, clinicians, and actually the instructions on some of these products that I see women buy at their health food store, it tells them to put it directly on their stomach or thighs. And that is not correct. And that is because these are fat soluble, and they will go to the fat and they will stay there, and you will wonder why, if you're measuring, the clinician will wonder why they're not seeing a significant response in the saliva, or they have done that for a long period of time, and now the hormone is spilling out, and they're getting very high levels in their saliva. So the thin parts of the body, the inner wrist and behind the knees, work great. I'd give you some ideas of, as you're walking through this, say looking at menopause women, 1 to 2 pumps per day. Some clinicians like to take a break on the progesterone application. Actually, Aaron and I do not recommend breaks. In fact, I've had patients tell me they wouldn't take a break because they feel so much better on it. Sometimes a woman who goes on progesterone initially may have a little spotting. That's actually a good thing because that means they're sloughing thickened, unnecessary endometrium, and that's called dysfunctional uterine bleeding. And so all you do if that happens, don't alarm them, and although they may be panicked, you simply say, oh, that's good. What we've done is we're cleaning out the uterus, and what I want you to do is when the bleeding stops, start the progesterone again, and if that happens another time or two, then you're just cleaning things out. Now, a caveat from a clinical perspective, if that goes on for 3 months, then refer the patient to their gynecologist for an evaluation. Now, in premenopausal women, again, 1 to 2 pumps per day, but generally that is dosed the latter 2 weeks of the menstrual cycle to mimic the luteal phase, or in some cases, if they're getting very close to perimenopausal, my usual practice is to just have the patient use the progesterone between periods. Now, if a woman is interested in conception, you will want to give her 2 pumps a day during the latter 2 weeks of her cycle, and you will not stop the progesterone. You advise them not to stop the progesterone until they have a menstrual cycle or a negative pregnancy test. And if conception does occur, and you will be surprised how effective you would be if you have a patient who's having issues with maintaining pregnancy, how effective progesterone is for that. So if they do conceive, they continue the 2 pumps of progesterone until the time of delivery. For the PMS patients, in 1 to 2 pumps a day, and the dosing is flexible. You can do it between periods, and sometimes you can actually regulate periods if they want to try and do that by cycling them 2 weeks on and 2 weeks off. Now, another product that is very helpful is the For Comfort product. And that product is basically Estradiol, and again it has 60 to 70 pumps, and the Estradiol level is 1.4 milligrams. And since that's the good estrogen, you can use this on the breast cancer patients. It is excellent for vaginal moisture repair, so it can be used intravaginally, and it is very effective for wrinkles. And it will correct the that EQ ratio that we talked about. If they're going to apply it to the vagina, they simply use their fingers, apply it intravaginally every other day until the moisture returns, and then they do it as they need it. For wrinkles, they can apply 1 pump a day to the region of interest, for example, around the eyes. Now, I wanted to in the next few minutes go over a case just so you had a feel for it, and this is just one example. This is a 31-year-old female, so she's premenopausal. And this is the 10 hormone panel that you could get from Labrix. And we have the, moving from top to bottom, we have the 3 estrogens, estrone, estradiol, and estriol, and the EQ ratio. And in her case, it's 0.8. So how would we manage that? And if you are thinking you would give the For Comfort product or Estradiol topically or vaginally or however they want to use it, but use it daily. Just to discuss the vaginal dryness situation for a moment. Once they've achieved the moisture they want, then they would apply the estriol to another part of their body, their inner wrist or behind their knees. So that ratio can be corrected with estriol. Her progesterone level is low, which suggests that she hasn't ovulated. So she's in that situation where she may not ovulate every cycle. So her PGU2 ratio is low, and we will correct that with progesterone or the For Balance CHANG product. Her testosterone is in a reasonable range, as her DHEA is low, and that is common. DHEA declines with age. Now, just as a point of discussion, you could treat her with oral DHEA, and a woman's dose is 5 milligrams. If you did that, you would push her her testosterone level up and also her estradiol level up. But if you look at her estradiol level up on the second line, she has plenty of estradiol. So I if she were my patient, I wouldn't use DHEA in this situation. If her testosterone were low and her estradiol were low, since you may not have privileges to prescribe testosterone, you could use DHEA to raise both of those. And her cortisol levels are showing an unusual pattern. She's actually at phase 1, and adrenal fatigue or adrenal dysfunction is a topic for another hour or two presentation. So we won't go into that. Now, I wanted to show you a couple of studies here. And if you look at this thermogram, and some of you may be familiar with thermography, if you look at the in the right breast at about 10 to 11 o'clock, there's a vascular pattern there that would be of concern to a thermologist such as myself. And this is the same patient. This is the same patient 1 year later after being placed on a breast health protocol. And the breast health protocol included progesterone, vitamin D, and iodine. And she has perfectly normal breasts now. In fact, her breasts after the breast health protocol are absolutely normal. And this is what she looked like before. Here's another case of a 49-year-old woman who had been diagnosed, excuse me, with DCIS, or ductal carcinoma in situ. She was treated with progesterone 20 milligrams twice a day, vitamin D 5,000 IUs, iodine 12.5 milligrams, and a vascular supplement. And on your right, the blue arrow shows where the DCIS was. And if you look at the pattern not quite a year later, you can see that the vascular patterns are much less prominent and much reduced in their prominence. And if you look at the red arrow, that's where the DCIS was. So a remarkable improvement in this person with DCIS. And now here's a publication that you may want to read if you are wondering about mammography and how that was pushed through. Basically, was a political decision to introduce that as the screening tool. And Dr. Handel Reynolds in this 2012 publication really does an amazing job, and he's a radiologist, actually. And here's one of the quotes from the book. One-fifth of the 2.5 million breast cancer survivors in the U.S. carry a diagnosis of DCIS. 50,000 women each year receive this diagnosis. He basically concludes that the breast cancer epidemic is due to mammography picking up lesions like DCIS, which are not going to harm the patient. And then he goes on to state that DCIS has a 10-year survival rate of 98% if you do nothing. And what is really scary to me and very sad is that 5% of the women who get diagnosed with DCIS have double mastectomies. All right, there's some other Kajaran products. We'll go over those in more detail at another time. But For Balance Plus actually has a bias in the formulation. So for women who do need progesterone and estradiol, you've got a product. And there also is a male product that has progesterone in a lower dosage, 12.1 milligrams, but it also includes chrysin. And the chrysin is an aromatase inhibitor. And so that prevents or reduces the risk of converting testosterone to estradiol. If you are interested in Kajaran, you can go to kajaran.com and you can download the account set up and get yourself started. Last slide is a promotion for our advanced workshop, which is January 16 to 17 in Las Vegas. It's a 2-day workshop. It's only $200. And by the end of that, you will know how to treat all of the hormone imbalances and neurotransmitter imbalances, as one of our test methods is also urinary neurotransmitters. And so if you can make this, Las Vegas can be fun that time of year, come down and join us. So that's the end of my presentation. I'll take some questions now if there are any.
Dr. J, I'm not seeing any up here yet, so maybe you can answer some of that they ought to be asking.
Okay. Well, one of the, here's a question I would ask. Is salivary testing useful for getting a heads up on metabolic syndrome?